The authors would like to present our arthroscopic suprapectoral bicep tenodesis using an Onlay technique. These are our disclosures. We commence the operation with diagnostic arthroscopy. Here you can see a superior labral tear extending underneath the bicep tendon as a slap tear. We complete the diagnostic arthroscopy and then move to the subacromial space, clear the bursa, and then shift the viewing port from posterior to the working port. We identify the bicep tendon sheath using the wave test and then bluntly open the sheath and confirm the bicep tendon is in the sheath. We then clear the space anterior to the bicep tendon so we can work with this. Next, a port is made directly below the viewing port, about 2 centimeters below it, and a kingfisher is used to introduce a suture tape with a loop suture on the end of it around the bicep tendon, locking the bicep tendon as a luggage knot. A penetrator is brought in through that port after positioning the suture anterior to the bicep tendon so the penetrator can pick it up. Here the penetrator is passed through the bicep tendon, picking up to the suture, so that the suture end is then brought through the bicep tendon, locking the construct. We use a working port on the anterior aspect of the shoulder directly above the bicep tendon and immediately superior to the pec major insertion. The awl is used to create a hole for the swivel lock anchor. This is a 5.5mm swivel lock anchor. We prefer biocomposite anchors. Anchor is brought in, and then after that the suture is cut to length using a suture cutter. And then we shift to the glenohumeral joint, viewing from posterior and introducing a arthroscopic straight punch from anterior to release the bicep tendon at its insertion. A shaver is then used to remove the stump of the bicep tendon from the glenohumeral joint. Post-operatively, we manage the patients in a sling for 6 weeks, and we avoid a maximal contraction of the biceps for 6 months post-operatively.